Assalamu alaikum wa rahmatullah. Today talk is about bronchoscopy in intensive care unit during mechanical ventilation of different critical care conditions. Let us start with this question. Why do you need practicing bronchoscopy in an intensive care unit patient? So the reason for bronchoscopy in ICU include to treat refractory lobar atelectasis affecting oxygenation and for double lumen endotracheal tube position confirmation and for marking location of airway fistula during mechanical ventilation and ICU stay, and also for localizing and treating bleeding site and for removal of accidental aspirated foreign body. For safe practice during mechanical ventilation, endotracheal tube size of 8 to 8.5 to ensure adequate ventilation is required. Also, sedate patient to level of Richmond agitation sedation scale, which is acronym is RAS, level of -3 to -5. Select and individualize the anesthetic drug to avoid airway obstruction and mechanical trauma and inadequate ventilation or barotrauma or inadequate anesthetic level with possible awareness and laryngospasm or bronchospasm during procedure. About physiologic effect of bronchoscopy in mechanical ventilated patient, it increases the airway resistance and partial occlusion of the airway by bronchoscope can increase airway resistance, which appear as the following: high peak inspiratory pressure and high O2 end expiratory pressure, that is intrinsic beep, the normal is 0.5, and low delivered tidal volume, the normal is 6 to 8 ml per kg ideal body weight, and elevation of heart rate. The procedure related barotrauma secondary to elevation of plateau pressure is rare. What you need to monitor during bronchoscopy of patient connected to mechanical ventilation. First, you have to increase the FiO2 up to 100 to maintaining oxygenation level, targeting oxygen saturation more than 94 and keeping mean airway pressure within normal, that is 5 to 10 cm watery. Also keep the plateau pressure less than 30 cm watery, and this is very important. And if it is more than 30 cm watery, minimally deflate the endotracheal tube cuff. Also you need to monitor positive end expiratory pressure, acronym as BEEP, and monitor inhaled tidal volume and exhaled tidal volume. The normal is 6 to 8 ml per kg. Refractory lobar atelectasis is the most common indication for bronchoscopy in ICU. It results from underdiagnosed acquired fungal pneumonia or resisting bacterial pneumonia, that is community acquired pneumonia or ventilation associated pneumonia, and inadequate humidification of mechanical ventilated patient. Bronchoscopy is not the absolute treatment of lung atelectasis secondary to mucus plug because it will reaccumulate. The absolute treatment in this case is to treat the hidden fungal pneumonia or resisting bacterial pneumonia. So check the fungal biomarker in bronchoalveolar lavage as galactomannan and 1,3-beta-D-glucan, as well as antigen antibodies and polymerase chain reaction testing are used when the culture and inconclusive or unavailable. Let us see the bronchoscopy procedure setting in neuro-intensive care unit. All neurologic intensive care unit patients on brain protective strategy like traumatic brain injury. The aim of brain protective strategy is to maintain intracranial pressure less than 22 mm mercury and cerebral perfusion pressure more than 60 mm mercury. Prolonged time of bronchoscopy will raise the intrinsic beep, leading to decrease cerebral perfusion pressure and increase intracranial pressure as well as decreasing brain oxygenation. Maintain sedation level of Richmond agitation sedation scale up to -5 and hemodynamic status. Keep the mean arterial pressure above 80 mm mercury and less than 100 20 mm mercury to maintain cerebral perfusion pressure and intracranial pressure within the target level during bronchoscopy. On mechanical setting, if capnography tracing showing elevated carbon dioxide, increase minute ventilation, that is respiratory rate and inhaled tidal volume, to maintain carbon dioxide level between 35 up to 40 mm mercury. If beep increase during bronchoscopy, minimally deflate the endotracheal tube cuff. Avoid refractory increase in intracranial pressure. Also increase the FiO2 up to 100 during bronchoscopy to maintain adequate brain oxygenation. Bronchoscopy in respiratory intensive care unit. Bronchoscopy in ICU patient connected to mechanical ventilation of lung protective strategy. Most ICU patients on protective lung strategy have low static lung compliance. That is, normal static lung compliance is between 45 up to 65. The aim is to keep the plateau pressure less than 30 mm mercury and keep the tidal volume between 4 to 6 ml per kg. Increase the flow rate if the delivered volume decrease as a result of flexible scope inside the endotracheal tube rather than increase the inhaled tidal volume. Maintain the oxygen saturation more than 88, and if it is low, increase the FiO2 more than 100. Check elevation of beep on ventilator scaler during bronchoscopy. If intrinsic beep is high, minimally deflate the endotracheal tube cuff instead of decreasing control beep. If patient have severe hypoxemia, that is saturation less than 88 on FiO2 100 and beep more than 18 and static lung compliance less than 15, in this condition bronchoscopy is not absolute contraindicated, because in such scenario bronchoscopy can be done in prone position. Bronchoscopy in cardiac intensive care cases. First condition is bronchoscopy in post cardiac arrest. Avoid bronchoscopy within first hour, that is golden hours of post cardiac arrest, and if bronchoscopy can be postponed to be after 72 hours, it will be safe. If bedside echo done as part of post cardiac arrest strategy component showing ejection fraction less than 35, avoid bronchoscopy if possible because it precipitates fatal arrhythmia. And finally, if bronchoscopy procedure cannot be avoided, maintain same setting of bronchoscopy in neurocritical care cases. Second condition is bronchoscopy in acute myocardial infarction and acute coronary syndrome. In this scenario, current guidelines recommend to delay bronchoscopy for 4 to 6 weeks after acute coronary syndrome, as this period is theoretically considered at risk of new onset acute coronary syndrome. Second thing, if bronchoscopy done in myocardial infarction patient, it precipitates arrhythmia and myocardial dysfunction. The last scenario can be occur is bronchoscopy in mechanically ventilated patient connected to extracorporeal membrane oxygenation. In such cases, the available studies of treating physiological changes and complications occur during bronchoscopy of mechanically ventilated patient connected to veno-arterial ECMO or veno-venal ECMO is scanty.